Welcome to Shades of Radiology. This is Dr. Nikita. I would like to discuss an interesting case with you. So, this is a 43-year-old woman with a chronic history of bilateral parotid gland swelling. She gives episodes of acute exacerbation on the left side. The swelling was non tender, progressive, not associated with fever or weight loss. Initially, an ultrasound was done, and in the ultrasound, bilateral parotid gland enlargement with multiple cystic spaces were seen. She was then subjected to an MRI, and the sequence is here. On the right side, you have axial T1, and on the left side, you have axial stir sequence. And as you can see, bilateral parotid glands are symmetrically enlarged and they show cystic spaces within them, producing the classic honeycomb appearance. With this appearance, the top differential on our list was benign lymph epithelial cysts, which is commonly seen in HIV associated sialadenitis. She was worked up for HIV, HBsAg, and HCV, all of which turned negative. Now, with these ruled out, what would be the next on your differential? So, I would like to show you two more sequences, two more findings. So, this is T2 coronal, which is showing that bilateral submandibular glands are enlarged as well, and they show cystic changes with some amount of fatty atrophy in it. This is post contrast Dixon sequence, coronal sequence showing bilateral symmetrical enlargement of lacrimal gland as well. Now, there was no focal lesion or diffusion restriction in lacrimal glands. So, now we've got bilateral submandibular and parotid gland enlargement with cystic changes and bilateral lacrimal gland enlargement. So, now the clinical suspicion at this stage turned to a chronic granulomatous disorder. So, top on differential was TB and then sarcoid. So, a true cut biopsy was taken from the parotid gland and that showed acute and chronic sialadenitis, no granulomas, and no caseation necrosis. So, now granulomatous pathologies were ruled out histologically. So, now what else could explain this constellation? Now, when the patient was questioned, when the clinical history was taken in detail, she gives uh, occasional dryness of eyes and dry mouth, especially early in the morning and during long conversations. So, and orbit MRI sequences revealed bilateral lacrimal gland enlargement. So now we've got chronic bilateral enlargement of parotid, submandibular, lacrimal glands, cystic changes and honeycomb appearance in parotid and submandibular glands, negative serologies, no granulomas in the biopsy, and patient is giving history of dry eyes and dry mouth. I think by now the diagnosis should be clear. So this is Sjogren's syndrome, which is a chronic systemic autoimmune disorder primarily affecting the salivary and lacrimal glands, eventually leading to glandular dysfunction. Now, there are two types: primary, which occurs in isolation, and secondary, which is seen in association with other autoimmune diseases like rheumatoid arthritis, SLE, or systemic sclerosis. Now, the key auto antibodies in Sjogren's syndrome is anti-Rho and anti-La. Now, this was positive in this patient. So, that MR finding, I wanted to elaborate a little bit on that. So, what happens is every time this parotid gland undergoes inflammation, cystic changes happen, and over time, the gland gets replaced by fat. Okay, so when you see fatty replacement, that means it is a chronic, it has been there for some time, and the microlobulated or cystic pattern is commonly seen in the acute phase. Now, in the imaging protocol, the sequences that is very important is T1 weighted and fat suppressed T2 weighted sequence. Now, this is a new technique, MR silography. This is actually a heavily weighted T2 sequence in which we are not giving contrast, okay, but we are having, without giving contrast, we are able to assess the parotid gland duct, the Stenson's duct, and it's primarily used for detection of calculi and for seeing if there is any dilatation of the duct or any obstruction in the duct. Okay, so this is MR silography. Now, this is the ultrasound finding of another patient with Sjogren's syndrome, and what you see, that patient had 4 episodes of bacterial parotitis And what you see in the ultrasound is a mottled appearance, which is because it's got multiple cystic areas. And lastly, I just wanted to touch on the xylogram. Xylogram is an invasive procedure in which we cannulate the parotid duct, the Stenson's duct, which is opposite the upper second molar. And once you have cannulated, you will inject iodinated contrast about zero point 0.5 to 1.5 ml. And once the contrast gets into the duct, you will give a xylagog like lemon juice or something to stimulate secretion, and then you will take delayed evacuation films. So basically, this is to look at the duct to see if there is any obstruction, to look for filling defects. Okay, now you can see in this image, this is a right parotid xylogram, and you can see that there is pooling of contrast in the damaged acini with a mild ductal narrowing proximal to the takeoff of the accessory lobe. Now, the problem with this investigation is it is invasive and it cannot be done in acute infection. So now this is largely being replaced by non-invasive techniques like MR xylography. So that is it. That was a case of Sjogren syndrome. Thank you.